Hello, everyone. Well, we will go ahead and get started today. Thank you so much for joining us for our third HIV echo session today. So again, thank you so much for joining us today. We are UNMC's Specialty Care Center, and this is our third HIV echo session. So that's Extension for Community Healthcare Outcomes. And our third session is all about STIs today. And our subject matter experts today will be Dr. Sara Hurtado-Bears, who's here today, and then myself as well. I will be presenting some case study questions to her. And my name is Heather Sorella. I'm also the HIV Echo facilitator. And then our sessions are held the first Thursday of every month, except January and July of 2025. And then this is just a disclosure that our HIV Echo project is made possible through our grant funding from ViiV Healthcare, and it's a sub-project of our I'm Capable research project. Alrighty, everyone, and this is just an agenda for the session. So Dr. Bears will kick off the session with a didactic presentation on our STI business. So we're really looking forward to that. And then I will be presenting a few STI treatment and diagnosis case study questions for her. And then we'll share some announcements at the end. And then these are just some housekeeping reminders for the session today, but we love discussion. Feel free to hop in the chat at any point with any questions if you'd like. Please stay muted unless you're speaking, one diva, one mic. And then we love to see your face if you're comfortable having your camera on, no problem if not. And then sessions will be recorded. Only the didactic portion will be recorded. We won't be recording the case study part just in case. And then we will have links available later if you would like that recording. And then we will have end of session surveys available as well. And I believe now I will be handing it over to Dr. Bears.
Perfect. Thank you so much for the introductions, and thanks everyone who is tuned in for this talk. Again, as Heather said, we will be talking about sexually transmitted infections, and this is a really broad topic, so lots and lots to talk about. And so we've limited the didactic session to some fairly, I think just some very basic overview, and then cases that we'll discuss in more depth. And if you have any questions or want to chime in, we'll try to make the discussion section interactive, but feel free to also chime in with questions as we're going through some of the initial presentation as well. And I will ask Heather, if you don't mind keeping an eye on the chat, and then you can interrupt if you see anything coming through. All right. This is just to put things in perspective and highlight the importance of this topic. We, in the last few years, have reached all-time high levels of sexually transmitted infections in this country, with increases across most of the most common STIs, including chlamydia, gonorrhea, but most importantly, a really significant increase in the incidence of syphilis, with an 80% increase in 2022 compared to the 4 years prior. And that translated to a 183-degree increase in cases of congenital syphilis. And so just a reminder of the importance of these infections and the real significant impact that these have. And this is just some of the local data to put things into context. The most common sexually transmitted infection that we see is chlamydia, followed by gonorrhea, followed by syphilis. And I just told you that syphilis is where we've had the most increase. And this figure makes it look like syphilis is not a major problem, but these are all in cases per 100,000 population. So these are all very common and something we see in our practice every single day. And unfortunately, Douglas County, I think a lot of times you'll hear, I think when I first moved to Nebraska, everyone said Douglas County has higher incidence of STIs than other parts around the country. And I kind of questioned it. And then I saw the data, and this is true. And so this is something to be aware of, that we do see per 100,000 population, we see higher rates specifically of chlamydia in Douglas County than in the rest of the country. This is also true, this is not the case for syphilis, where the incidence in Douglas County is still lower than the United States, but you can see in both Nebraska, which is in red, and Douglas County, which is in blue, we've seen significant increases over the last 5 to 10 years. So that's highlighting the importance, the real prevalence of these infections and the importance of being aware. And so taking a back step as we think about, well, what can we do as providers to better screen and help patients become aware of these infections so that we can reduce onward transmission. I want to go back to the most important step, which is taking a really thorough sexual history. And I think this is something we all learn in medical school, but we don't get good at until years of practice. And I would say this is something that I am still working on, in spite of the fact that I do this every single day with patients. I think there's always room for improvement and ways to make sexual history more comfortable, both for the provider and the patients. And so here are some tips that I've learned from some of my mentors over the years, and hope to share with you. The most important thing is to really create a comfortable environment. Make sure you're having these discussions in a private space, setting a tone that makes the patient feel comfortable. So being at eye level, I think a lot of these things are always, we're taught about them. And then when we go into practice, it takes more time to sit down. It takes more time to make sure that our staff, we have condoms available and that, everything, the whole space is a friendly, comfortable space. And so we can't overemphasize how important that is. This next point is, I think, probably the most important for me, which is that practice makes perfect. And so again, something that I am still working to perfect. And I think the hard thing about this is we can't really teach one way that works for everybody, but it's really important to practice so that you can figure out what works best for you, and so that you can hone your language over time. And it's not going to be the same language for every patient. And so we'll get to that in the next slide, but I have learned over time that it's often more comfortable if you can start sharing the patient's language. So if a patient is using some terms, that you can echo those terms, and that will make it more comfortable. But that does make it so that the history is different with every single patient. I like to start with a little intro, something that can just emphasize the importance of sexual health. And so to really take the stigma away from infections, but just emphasize that we care as much about that sexual health is a part of physical and mental health. And so I start with something that says, I'm going to spend a few minutes talking about your sexual health, because sexual health is an important part of general health. And then really, even though it takes more time, asking open-ended questions is key. So starting with really open-ended questions, if you don't get the answers that you need with those open-ended questions, then you can go to more pointed questions. But just starting with questions like, tell me about your sex life, asking for the biggest concerns about sexual health can be really, really helpful and set a tone to give the patient room to talk. And then again, just letting the patient lead, and then asking follow-up questions from there. There's a great febrile podcast that one of the people I very much admire, Dr. Anu Hazra, who's at University of Chicago, is the discussant on this. And so if you want to go more in depth on just taking a sexual history, this is a great podcast to listen to. The other tips that we've learned over the years that really help us make sure that we don't miss any important component of the sexual history is the mnemonic, the 5 Ps. And so this helps us remember to ask all the elements of the sexual history that will help inform our testing, our guidance, and our counseling. And so the 5 Ps, partners, so we can ask our patients to tell us about their sexual partners, ask about the genders of their sexual partners. In medical school, we're taught to say, do you have sex with men, women, or both? Or at least I was in medical school a long time ago. So hopefully many of you didn't learn this, but that can be gendering, and it can lead us to miss things. And so that is a question that I've learned to shy away from, even though it was so ingrained in me and how I was initially taught the sexual history. Asking about practices. So really, in order to understand our patient's risk for STIs, we need to understand what kind of sex they have, and saying it just that way is helpful. And again, you can reflect the language that the patients use, and it's okay to avoid that, or it's better to avoid the complex language. So what you discuss in the patient room may be very different from what we document in the chart. But there are many different ways that you can ask these questions that I've listed in the slides. So we can ask things like, do you have penis and vagina sex or penis and butt sex? Are you top, bottom, or both? If we have a patient, a man who has sex with men, or you can ask about other types of sexual behavior. So lots of different ways of asking these questions. Asking about past history of STIs, it's important. That'll help inform how you interpret the STI testing. It'll help understand what patients know and don't know about a lot of times it just helps me assess their health literacy. Remembering that some STI prevention is also prevents pregnancy, but not all. And so making sure that that's also a component of our sexual history. And so asking what patients are doing to either if they're planning for pregnancy, if they're hoping to prevent pregnancy, and then asking about protections from STIs. Any questions or any other tips that others on the call have learned over the years and can share with the group? And so feel free to put them in the chat because I'm always learning from my colleagues about helpful ways to make the sexual history more comfortable. So then we'll move on to STI testing. And really the reason for starting with those couple slides about the sexual history is because we use our history to inform what kinds of screening tests we're going to offer. And the most important thing for, I think, everyone on this call to know is that the majority of STIs are asymptomatic. And so over half of chlamydia, gonorrhea, and all of the most common STIs have no symptoms whatsoever. And so it's really important to perform STI screening regardless of whether or not a patient is having symptoms. And so these are the tests and the recommended demographic groups that we will test and the frequency. So which STIs do we test for when a patient is symptomatic and which groups? And so you've already had your talk about HIV 101. Remember that this is a universal screening. So again, no symptoms, but everyone should be screened once in a lifetime. And then people who have other risk factors, pregnant women need to be screened both in the first trimester and the third trimester if they have risk factors. And then sexually active gay, bisexual, or other men who have sex with men should be screened at least yearly. Chlamydia and gonorrhea are more we expand the groups and the frequency of the testing a bit more. And so sexually active women under the age of 25, women who are over 25 but have risk factors should be screened yearly. Any pregnant woman who has risk factors should be screened. And then sexually active gay, bisexual, or other MSM should be screened at least yearly. Syphilis, we used to only screen pregnant women in the first trimester, but because of the uptick in cases nationally and the significant increase in congenital syphilis, we now recommend screening in both the first and the third trimester of pregnancy, and then yearly for our last demographic group. And then Hep B and C, really just pregnant women are the groups recommended by the CDC, and then Hep C yearly for our last demographic group. I will put a caveat here that these are the currently guideline recommended screening groups. The big thing is if you ever have a patient who comes into a sexual health clinic or into your clinic and asks for STI screening, regardless of whether, even if they're asymptomatic, if they don't meet these demographic risk factors, please screen. Patients aren't always comfortable sharing risk factors, and that's on us. We are not always, as a healthcare system, often ends up on their chart, and then there's a lot of stigma that can be associated with this. So anyone who asks should get STI testing. And then I will also point out that there are some STIs that are not listed here because screening does not actually provide any benefit. So you'll notice that, for example, herpes simplex virus, HSV, is not listed here. Patients often come in asking for HSV testing, but the utility of HSV testing in somebody who is asymptomatic without a lesion is there is a bit controversial. And so there are STIs that are not listed here. Okay, so those are the general screenings. And then now you know what to test for, but the big question is, how do you do what testing do you order? And then how do you treat if they are positive? So we'll go through the different STIs. HIV, I think, again, you've already focused on, but I always like to convey a couple of teaching points about HIV testing. In our clinic, we see a number of patients who get misdiagnosed with HIV or the converse, where they had a prior HIV diagnosis but were never referred because of the testing was misinterpreted. And so key take-home points is never make a diagnosis of HIV with one test alone. Our screening test is purposely very sensitive so that we don't miss any false negatives, or sorry, false positive, or yes, so that we don't have false negatives. And so there will be false positives. And so if you screen somebody for HIV and their screening test, which is now a combination antigen antibody test, is positive, we need to do a confirmatory test before you tell the patient that they do indeed have HIV. If the antibody portion of the screening test is positive, we follow up with an antibody-based differentiation assay. If the antibody-based differentiation assay is positive, you're done. They have a confirmed diagnosis of HIV, and you can refer them on for follow-up of the HIV. If the antibody differentiation is negative, they need a third test. They need a tiebreaker. So if you have a first screening test that's positive followed by a second test that is negative, you need a tiebreaker test, and that's where we reflex to our nucleic acid test, NAT, also called RNA or a PCR or a viral load. Those are all synonyms for the same test. But again, we do need a tiebreaker test, and that's because you don't want to miss early HIV. If the antigen component of the screening test is positive, then we need to bring the patient back for a nucleic acid test because that's early in the disease before the patient has developed antibodies. And so the antibody-based confirmatory test won't work, but the RNA, which appears before the P24 antigen, will be positive. And so that's when we use the RNA exclusively as our confirmatory test. This is just the sequence of lab markers in HIV to help you understand that testing. So a couple things to point out. There is a window period. So from the time of exposure to the time where we can do any lab test to detect HIV after a person has been exposed and infected with HIV, it's going to be at least a week. We occasionally have patients come in for post-exposure prophylaxis evaluation, or and wanting a test to know if they were infected with HIV immediately after the exposure. And it's really important to remember that we don't know, because there are no laboratory markers, no laboratory tests that can be done immediately following an exposure to tell whether or not somebody has acquired HIV. The first laboratory test that will turn positive after exposure to HIV is the RNA. But again, that takes at least 10 days. And that's not a test that we use for screening upfront because it's expensive and you can have false positive. It's not validated for screening. But it is a test that if you suspect acute or early HIV, that is a test that you should do. The next test to turn positive is the P24 antigen. And as that peaks and then declines, that's when antibody forms, but antibody doesn't form until a few weeks after exposure. And so if a patient does, for example, a home-based HIV test, like a oral or a quick swab, which is an antibody-only based test, remember that you're going to have a window period of at least 3 weeks before your test will be positive. That's all I have about HIV. Any questions before I move on? Okay. So the next tests that we'll talk about are gonorrhea and chlamydia, or Neisseria gonorrhea and chlamydia trachomatis. These are always, whenever we test for gonorrhea, we test for chlamydia and vice versa, because we frequently see co-infection, and because they have very similar manifestations. And so they can both present with urethritis and the same myriad of manifestations. And similarly, they are both most frequently, so the most common presentation of gonorrhea and chlamydia is no symptoms. So over half of these infections are asymptomatic. It's really important when we are screening for chlamydia and gonorrhea to screen based on your history. And so this is where your sexual history is really going to guide which test you use, because it's important to assess what sites of a patient's body may have been exposed to one of these one of these pathogens before we test. And so if we can do testing of the urine, we can do testing of the vagina or endocervix, testing of the rectum, and testing of the oropharynx. And it's important to know that the urine is just as sensitive or has a similar, it's more sensitive than a urethral swab for men. And so we no longer do urethral swabs, thankfully, even though many patients still worry about that. But for women, if you are very concerned, the vaginal swab or endocervical swab is more sensitive than the urine. For convenience and to increase adherence and uptake of screening, a urine is as adequate in a woman. Otherwise, you need to do a rectal swab if their rectum is exposed or an oropharyngeal swab. And what's key is we need to swab all exposed sites. Most infections, again, are asymptomatic. And at our clinic, we did a study probably 10 years ago now, but a really important finding that has been replicated at other sites and is the reason that we screen all sites. If we had only screened the urine, we would have missed all gonorrhea and 75% of chlamydias that were outside of the genital tract, so outside of the urine. So really, really important to screen all exposed sites. And then many of the kits come with 2 swabs. And so important to note that the flocked swab, the kind of flimsy swab, is meant only for endocervical collections. And so I throw that one away if you're giving patients these swabs so that they can self-collect. Throw that flocked swab away. Otherwise, the lab can reject the sample if it's collected on an inappropriate swab. For treatment in the case of asymptomatic infection for gonorrhea, the treatment is ceftriaxone. It's important to remember that it is weight-based, and we have an increasing prevalence of obesity in our population. And so if a patient is over 150 kilograms, we do need to give the higher dose. We have moved away from the dose of ceftriaxone has come up in recent years because of increasing resistance among our gonorrhea isolates. And so there is increased cephalosporin resistance, which is why we give a higher dose, and which is why it's even more important to make sure that we're giving the appropriate dose in patients who are above that 150 kilogram weight. The treatment for chlamydia is doxycycline, and it's a 1-week course of 100 BID of doxycycline. It's important to provide appropriate counseling and follow-up. And so we recommend that patients abstain from sexual activity for 7 days after treatment. And most importantly, until all sexual partners are treated. That can be the most difficult part because we don't always get confirmation of that. We encourage patients to notify any sex partner that they've had within 60 days of the diagnosis of their STI. And then what sometimes gets forgotten is to offer additional STI testing. And so even if you only screened for chlamydia and gonorrhea, if they acquire chlamydia or gonorrhea, they are at risk for acquiring the other STIs that we talked about at the very beginning. And so important to complete the other comprehensive STI testing to ensure that they are not co-infected with another STI. And then this is a great opportunity to offer HIV pre-exposure prophylaxis or doxy post-exposure prophylaxis. Since those are recommended in anyone who's had a bacterial STI in the last year. Partner therapy is really critical. And fortunately, in Nebraska, we can offer expedited partner therapy. It's really only possible to implement this in the case of chlamydia because for gonorrhea, it's an intramuscular ceftriaxone injection. But this is important to do when you're able to. And then the critical thing that I think frequently is hard to implement and sometimes gets missed is that we need to do repeat testing. So all patients should come back in 3 months for repeat testing to assess for reinfection. Reinfection is very common, and the most common reason that we see we sometimes think that the patient fails to clear their chlamydia or gonorrhea. It's not because they're resistant, but because they are reinfected. They're exposed to a partner who hasn't yet been treated. The one bacteria that is a little bit harder to eradicate is oropharyngeal gonorrhea. Some people are colonized with non-gonorrhea strains of Neisseria, and it's just more difficult to eradicate with treatment. And so if you have a patient with oropharyngeal gonorrhea, they need a test of cure, not just a test for reinfection, but a test of cure 7 to 14 days after finishing therapy. Any questions about those?
Yeah, Dr. Bears, I have a question in the chat. A great question for you. Um, Sarai, I'm sorry if I mispronounced your name, said, as doxypep is now readily available, like at Douglas County, does doxycycline become resistant to the point someone did need to be treated? Would doxycycline not work? Or would there be like some resistance there with this like surgence of doxypep?
Yeah, good question. So doxycycline, for those who don't know, doxycycline as I probably should have defined it, or doxycycline as post-exposure prophylaxis is now been studied in multiple randomized trials and proven to be effective. So this is giving doxycycline 200 milligrams within 72 hours after a possible sexual exposure to an STI. And it's highly effective, reduces the incidence of chlamydia by 2/3, syphilis, less effective for gonorrhea because doxycycline isn't as active against gonorrhea. And so, and then so very effective and really exciting to see this being implemented in health departments across our state and in clinics across our state because it's such an effective tool. There are some limitations to doxycycline post-exposure prophylaxis. Doxycycline is not without any side effects, and so always important to counsel patients about side effects. And then the big one that's come up that this question gets to is resistance. And so will these bacteria that we're preventing with doxycycline ultimately become resistant to doxycycline? And that's has yet to be determined in the literature. The literature has looked at, for example, methicillin resistance, colonization, or MRSA, methicillin resistant Staph aureus colonization, and we do see a little bit of an increase in resistance to tetracyclines with MRSA. There's been some signal of perhaps more resistance among some of these other bacterial STIs, but nothing that has warranted enough concern to pause this or, give caveats to the recommendation. So I wouldn't be concerned about resistance, but what we see is that patients are kind of self-treating. So for example, I just had a patient this morning who I have on doxypep, and he told me that anytime he gets a symptom of a UTI, of an STI, while he now just takes a few extra doses of his doxycycline. So instead of just using it as post-exposure prophylaxis, he's kind of been self-treating his STIs. And I think the risk there is we don't know if he's trying to treat gonorrhea, which wouldn't respond to doxycycline, or is this not an STI at all, or does he need a diagnosis so that we can then treat his partners, et cetera. And so I think there's a and then on the other hand, what is it? We'll talk about syphilis in a minute, but doxycycline also has activity against syphilis. So how to interpret syphilis serology in the setting of doxycycline? I think it's raising a lot of really important clinical questions. But to get back to that excellent question that was just asked, I would say I wouldn't worry as much about resistance just yet, but just inadequate therapy of, for example, gonorrhea. All right, perfect. I'll move on. And then if other people have additional questions, feel free to chime in. The next one that is important to screen for is syphilis. And this is where I think I could spend a whole 2 hours talking about syphilis serology because it can be very challenging to interpret. But just to provide an overview, just like HIV, the key with syphilis is you never make a diagnosis of syphilis with one test alone. Our screening tests are purposely very sensitive, and so we need both a screening test and a confirmatory test before you ever make a diagnosis of syphilis. The other key is that to test for syphilis, we have both treponemal tests and we have non-treponemal tests. And there are a couple of key facts that you need to know about these tests. The first is that treponemal tests, so your EIAs, your TPPA or FTA ABS, this is like your syphilis IgG is one of the ones that we start with. Those are positive for life. So once infected with syphilis, you will always have a positive treponema test, and this is positive for life. So you can't tell whether or not somebody has an incident syphilis with a treponema test alone. And so the testing is slightly different for somebody who has a prior history of syphilis versus somebody who's never been diagnosed with syphilis. Either way, we start with our treponemal testing, and then we reflex to the non-treponemal test, which in the serum is typically our RPR, and the CSF is our VDRL. And that will give you a quantitative result. If your treponemal test is positive and your RPR is positive, that means that you have syphilis, either past or present. So if a patient has a prior history of syphilis, that's when we need to know what that titer was and how does a titer from today compare to the titer that they last had. If a patient has no prior history of syphilis, then you're starting off with a new diagnosis of syphilis if you have both a positive treponemal test and a positive RPR. If your treponemal test is positive and your RPR is negative, that's when you reflex to your tiebreaker test. So just like in HIV, we had a tiebreaker test. In syphilis, we have a tiebreaker test. In this case, it's either your TPPA or your FTA. If both of your treponemal tests are positive, that means the patient does have a history of syphilis. But again, if they have a past history of syphilis, those two tests are positive for life. So that doesn't mean that they have a new diagnosis of syphilis. But if they've never been diagnosed with syphilis before, then they do have likely syphilis, and you need to be treated. If the treponemal test is the very first screening test is negative, this means that they likely don't have syphilis except in one situation, which is early primary syphilis. So if their manifestation is a chancre, or if they tell you they were just exposed to an STI 1 week ago, then there is still the possibility that they do have syphilis or were truly exposed and infected with syphilis, but it's just that our tests are not positive yet. And then just to have a good graphic for you about how to interpret those RPRs, remember we said that the treponemal tests are always positive, but it's the RPR that correlates with disease activity. And what we expect is a fourfold change. So in order to diagnose a reinfection, it means that we need to see a fourfold increase in the RPR. So if the patient had an RPR of 1 to 8 6 months ago, and today when you see them and screen them for syphilis, their RPR is 1 to 32, that is indeed a fourfold increase. It's a two titers increase, but a fourfold increase, and that means they have a new infection and need to be treated. Anything more than fourfold is consistent with the new infection as well. So it just has to be fourfold or higher. If it's just a twofold increase, it's within degree of lab error. Remember, these tests are done manually. And my favorite syphilis expert, Dr. Khalil Ghanem, gives a great lecture where he talks about just how antiquated RPRs are. They were first developed when we were driving really old cars, and yet this is still the test that we use to this day. And so know that it is not a perfect test and needs to be interpreted with some degree of caution. And if you have any question about it, ask your lab to repeat it, because remember, it is a manual test and subject to human error. And so if the result that you get from your lab doesn't match the clinical situation, don't be afraid to ask the lab to repeat the test. The reason it's so important to establish whether or not a patient truly has reinfection and to establish a time frame is because the treatment for syphilis varies depending on the stage. So for early syphilis, which is either primary syphilis, secondary syphilis, or early latent, which is less than a year from their last infection, then or last negative test, then we can just give 1 dose of benzathine penicillin. Whereas if a patient has late latent or syphilis of unknown duration, so if their test was their last negative was more than a year ago, then we need to give 3 doses of benzathine penicillin. Any questions about syphilis? All right. And then the last the last STIs that are important to screen for, because again, also asymptomatic, are hepatitis B and C. And just to give a few pointers about the serology. So in order to screen for active hepatitis B, it's important to check all three key serology. So we want to check our Hep B surface antigen. That's a protein that's on the surface of the virus and is detected in high levels during acute and chronic infection. And this is really what defines active infection. And so key to check hepatitis B surface antigen. And I think that most often gets checked, but sometimes gets forgotten to check for surface antibody, which indicates immunity. We don't know if this immunity is natural immunity or vaccine immunity, but it indicates immunity. And the reason that's important is because if somebody is non-immune to hepatitis B, but has risk factors for STIs, this is an important opportunity to vaccinate because we have a very effective hepatitis B vaccine. And what sometimes gets forgotten, but is very important to check, is your total Hep B core antibody. This appears at the onset of symptoms and it persists for life. And so this helps differentiate natural immunity versus vaccine immunity. But occasionally we see patients with a positive Hep B core antibody without surface antibody. So they had a prior infection but never developed immunity, or without surface antigen. And this could be a marker for chronic infection. And so if they have a positive Hep B core antibody without immunity or without evidence of active infection, we need to look for active infection with a Hep B DNA and do follow-up testing. So really important to screen for all three if you're going to screen for Hep B. And then for Hep C, we do antibody-based testing with a reflex to a viral load or a Hep C RNA if that antibody is positive. So Hep C, the antibody can be positive just with past disease, even if a patient clears their infection, and most people will clear without treatment. And so it is important to confirm infection with an RNA, but really important to remember that the antibody, unlike many other infections like hepatitis B, the antibody is not actually protective against future infection. So if a patient has a history of Hep C where they either were treated or cleared on their own, if you want to screen for reinfection, that's where we need the Hep C RNA. And that's all I have. So if there are no questions, we can move into the case studies. We have time.
Yeah, Marcy had a great question in the chat, or I don't know if she would just want to say it real quick on.
Oh yeah, can you guys hear me?
Yeah.
Okay. Okay, so this has come up in very recently. Says, I mean, we've all seen an increase in syphilis, but so we have a refugee clinic at Lancaster County Health Department, and we are seeing a decent amount of folks that come through. They have a reactive IgG, non-reactive RPR, and a reactive FTA. And we've had these case reviews and discussions because, as doing disease investigations and we follow this, surveillance algorithm, if the patient didn't have any signs or symptoms of primary or secondary syphilis, but they also have no documentation of previous history or treatment, from a surveillance standpoint, this wouldn't meet the definition of a new case. However, providers are like, okay, well, we still feel like we need to treat. I guess I'd just like to hear Dr. Baer's, I don't know, anything you have to say on that.
Yeah, so I guess, so from a provider standpoint, we do need to treat because that could represent latent disease. And so sort of late, and if you don't have a prior one, then it's latent of unknown etiology. And so it does merit treatment. I guess the one clause is if they have symptoms concerning for secondary syphilis with that serology, the one thing you have to be concerned about too is a prozone reaction where you have a false negative RPR. And so asking the lab to dilute the RPR to see if it's just
write this down.
So high. Yeah, that's important. But otherwise, I think the reason we distinguish it from a more public health standpoint and it doesn't meet surveillance is there's nothing to monitor to look for a response to therapy in this situation. And so although it is a true infection and without a prior known history of treatment or diagnosis, we have to count it as, we have to treat as latent or latent of unknown duration, there is nothing that you would need to follow to assess response to treatment, so long as you confirm that the RPR is truly non-reactive and not a false negative.
And can you tell me again how we determine if it's, make sure it's not a false negative? Can you say that part again?
You just ask the lab to further dilute it.
Okay. Okay.
And
Thank you so
that's
much.
uncommon. So it would only be if somebody has a rash and like looks like secondary syphilis, but their RPR is negative. Yeah.
Okay, that would be only do that in that type of a situation.
Yeah, if they have symptoms that are clearly suggestive of syphilis, but somehow you're still getting a negative RPR.
Okay.
I wouldn't do it if they have no symptoms whatsoever and it was just done for screening purposes.
But if there was no symptoms and a negative RPR, you would still treat because we don't have documented.
Yep.
Yeah. But surveillance is different, obviously, I know. But okay. Thank you so much.
Yeah, of course.